Perfect. Thank you. And thank you everyone very much for joining us this afternoon. We're very fortunate to have a great talk ahead of us. And so we're happy to present ACT, Adjuvant CDK4/6 therapies to improve long-term outcomes in high-risk early breast cancer. If everyone sees that QR code on the front, we kindly ask you to please scan it, complete a short pre-test, and at the end there'll be a post-test and evaluation to be completed as well. And additionally, if you have questions that come up throughout the talk, please put them in the chat and we'll aim to answer them at the end of the session. And so with that, I'm very pleased to introduce our well-esteemed speaker, Professor Stephen Johnston. He's the head of the breast unit, professor of breast cancer medicine, and a consultant medical oncologist at the Royal Marsden NHS Foundation Trust and the Institute of Cancer Research in London, UK. I'm also happy to thank our expert reviewers who are part of the scientific planning community, Dr. Christine Bresden-Maisley, as well as Dr. Mita Manna. Next slide. These are our disclosures. Next slide. And then this program has received an educational grant and in-kind support from Eli Lilly Canada, to which we thank them for, to the not-for-profit physician organization, the International Center for Professional Development in Health and Medicine. And then the information and the recommendations are evidence-based, and any opinions of the speaker will be clearly identified. And this content was identified, reviewed, and validated by an independent scientific planning committee. And we've completed all the conflict of interest disclosures. For those who are Royal College specialists, this is an accredited program. You can see in that section 1, learning activity, you may claim 1 maximum hour. And then for all other health professionals, this is a professional learning activity, which provided up to 1 hour of continuing education. And then our learning objectives today. So at the end of the program, participants should be able to evaluate the latest evidence from key adjuvant CDK4/6 inhibitor trials to inform clinical decision-making in high-risk hormone-positive, HER2-negative early breast cancer, identify and stratify patients who are most likely to benefit from adjuvant CDK4/6 inhibitors, incorporating best practices for treatment selection and sequencing, implement interventions to optimize adjuvant therapy in early breast cancer, include appropriate monitoring, adverse event management, and adherence support. And then assess future directions and evolving clinical strategies to improve long-term outcomes in patients with early breast cancer. And so with that, we welcome Professor Johnston.
Jennifer, thank you very much indeed. And it's a great pleasure to join you all in your lunch break. It's 5 p.m. here in London in the UK. So we're going to break this into sort of 4 sections. Initially, we're going to look at what the risk of recurrence is in hormone breast cancer, how we actually establish that, what we use in terms of anatomical, biological features, and look at some real world evidence in N0 and N1 early breast cancer. So let's kick off with that topic now. So these are data many of you may have seen from the PAN paper in New England Journal nearly 10 years ago now. And this looked at the long-term outcomes of women with T1 or T2 tumors in over 78 trials treated with endocrine therapy. And you can see that the factors that determine risk of recurrence are clearly related to anatomical pathological features, grade, nodal burden, and tumor size. And therefore, even in small T2 N0 tumors, there is an ongoing rate of recurrence. We know that in ER-positive breast cancer, that the risk is not necessarily in the early phases. It may be over a prolonged period of time. And these data establish quite clearly that grade, nodes, and tumor size are relevant. But it's important to also understand that biology also is highly relevant. And these are also some other data that come from the Spanish group, more modern studies in patients who've received adjuvant taxane and anthracycline chemotherapy and aromatase inhibitors, the GICAM studies. And in this particular study here, you can see patients who have these high-risk features, 4 or more nodes, or if 1 to 3 nodes are grade 3 cancer, you can see the steady rate of recurrences despite standard of care treatment, such that by 5 years, between 20-30% of patients may have relapsed, 40 to 50% by 10 years. And there's a steady rate of recurrences, which we'll talk about later. So anatomical features are important, but as I was alluding to, biology is as well. So we increasingly now look at aspects of that, particularly using molecular genomic scores such as the Oncotype recurrence score. And this looks at two components of the tumor, the proliferation and the estrogen receptor signaling. And you can see in the graphs on the right, the positive correlation, the higher the score, the higher the proliferation, the higher the score, the lower the estrogen receptor signaling. So these factors drive risk of recurrence in the biology of the cancer. And if you look at the B14 trial in node-negative patients with just tamoxifen alone, you can see the 10-year rates of recurrence markedly differ between those with a low, intermediate, or high-risk score. And this score has come into clinical practice based on studies such as TAILOR-X and RxPonder to help work out who may or may not need chemotherapy, particularly in the N1 and the N0 patient groups. So let's have a couple of cases to make it a little bit more real and work this through. So here's a 61-year-old postmenopausal patient, screen detected 2 centimeter tumor, grade 2 on core biopsy, hormone positive, HER2 negative. Staging was clear, but the nodes looked involved. She had her surgery, made a good recovery, and the pathologist said it's a grade 3 cancer in actual fact, 2.1 centimeter. There's a little bit of lymphovascular invasion. 1 out of 3 nodes are involved. Hormone positive, but low PR score, high Ki67. So the MDT discusses it and says, let's get a profiling to see what the risk of recurrence is in this N1 postmenopausal patient and whether there's any benefit from chemo. So you get the score back and it's 23. And this is always the very difficult number to cope with because 25 is a cutoff and we know very much that over that you need chemo, but around about 22, 23, what is that actual risk of recurrence? Well, the data from the trial here, which is RxPonder, would suggest that there is a relatively low risk of recurrence and no benefit from chemotherapy. But the issue is it's a grade 3 cancer. There's lymphovascular invasion. It looks like a luminal B cancer. So what is the real risk of recurrence? Well, nowadays we know that you can incorporate into the score the clinical prognostic features as well. Age, tumor size, grade, and nodal involvement. You get a little bit more accurate estimate of risk of recurrence and a little bit more accurate estimate of a potential chemotherapy benefit that you may then wish to go and discuss with your patient. But let's look at some other new data about this N1 patient group, about what their true risk of recurrence is. And this is a Flatiron database that was published last year. Hope Rugo was the first author, now published in ESMO Open very recently. And what this estimated was what's the risk of recurrence in a real world setting for patients with N1, that's 1 to 3 nodes, who either have the high risk features of grade 3 or large tumor size, or who don't. It might be a smaller grade 2 cancer, low proliferation, etc. And you can see the marked difference here in risk of recurrence at 5 years with a delta of 14.3%. So you double the risk of recurrence by just adding that feature of grade and tumor size to the same nodal burden. And that influences the overall survival. So again, a doubling of the risk of death if patients have these high risk features. So it is highly relevant even in 1-1 disease to layer on top the grade and or the tumor size to get a much more accurate risk of recurrence. Here's a second case, a younger 44-year-old premenopausal patient who has a symptomatic mass. It's around just under 2 centimeters, unifocal, grade 2 on biopsy. Again, the pathologist says in reality it looks like it's grade 3 with a little bit of lymphovascular invasion, but the nodes are clear. It's a much stronger hormone positive cancer, ER and PR 100%, HER2 negative, Ki67 again over the 20% mark, and she is still premenopausal. So again, there's a debate about whether an Oncotype test would help here to assess the recurrent risk and the benefit of chemotherapy in this woman under 50. And again, if you look at the data from the TAILOR-X trial and look at, again, a score of 16 in this particular case, you can see that, again, overall, it says there's no apparent benefit from chemotherapy and the risk of recurrence at 9 years is very low. But again, look at the table in the bottom left-hand corner there, and you can see that there's a lot of nuanced differences in women under 50, dependent on what that score is. If you're right down at the score of 0 to 10, there's no benefit. If you're in the 21 to 25, there's 6% benefit. So it's not that binary. There's probably a gradation of effect of chemotherapy over that period of time. And again, this allows us to go and have a detailed discussion with a patient about the benefit of chemotherapy. But again, this is something that comes back to the MDT. It's a grade 3 cancer. Do we believe what the oncotype is telling us about the benefit of chemo, or do we layer on top the clinical pathological features? And again, if you do that in terms of age of the patient, tumor size and grade, again, you get a more accurate estimate of risk of recurrence of nearer 10% and a chemotherapy benefit of about 2%. So I just use these cases to illustrate really two things: that the anatomical features are clearly important in N0 and N1 disease, but biology is also important on top. Again, real world data with the N0 patients was published again from Camille Javeri at ESMO 2 years ago. And what you can see here in another data set of 15,000 patients in the Flatiron database, where you can see here in the N0 patients how much better they do by and large compared to N1 or N2 to 3. But take the N0s and split them based on whether they've got increased features. And this is exactly what was done in the Natalie trial, which we'll come on to talk about. And if you can take a tumor that's a small tumor and it's either grade 3 or of grade 2, add a Ki-67 or a higher oncotype score, all of a sudden you split that into a group that is N0 high risk, having the same risk of recurrence as N1 overall. It's only around about 12% of all the N0 patients, but again, it's important to identify them because you can pull out a group that do carry a much higher risk of recurrence. And that was what was done in Natalie to pull out those patients in N0 disease. So clinical pathological features, strong prognostic factors. Biology, strong prognostic factors as well. Not all N0 and N1 patients are the same. The additional factors in N1 double the risk of recurrence or death. The additional factors in N0 triple the risk of recurrence. And I think these features are really important in our teaching and our assessment of risk of recurrence in the modern era. So let's look at the second aspect now, which is to say, well, okay, we get an estimate of risk of recurrence. How do we do with our different endocrine therapies? How can we improve outcomes in early breast cancer? In particular, how can we cure more patients? The ultimate aim of treatment is to improve overall survival. How much do we achieve with tamoxifen? How much better are aromatase inhibitors treating for longer, ovarian suppression, etc.? Well, adjuvant endocrine therapy owes an awful lot to this gentleman, Craig Jordan, a British scientist who sadly died just 2 years ago. He was doing his PhD in Leeds and was interviewed by Arthur Walpole, who from ICI, who was developing a drug for fertility, which ended up being tamoxifen. And it was Craig Jordan who took the drug after his PhD and then said, look, let's try and see if it works for breast cancer. And the rest is kind of history, really. The EBCTG trialist groups showed the benefits of tamoxifen compared to no treatment. And this was looking at the trials that were done in those days of tamoxifen versus no therapy in 7,000 women. You can see the big impact it has on reducing risk of recurrence compared to not taking any therapy. And this is some of the best evidence to tell us that hormone treatment really produces nearly a 40% reduction in risk of developing a recurrence of your disease. Aromatase inhibitors came along in the early 2000s, and they are clearly better than tamoxifen by a little bit more, a further reduction in risk of about 20%. That's the RR value, absolute gain around about 3% at 10 years. And that was enough to change practice in postmenopausal women pretty much from 2004, 2005 onwards. So what about the impact on overall survival? Well, again, if you look here at aromatase inhibitors versus tamoxifen, the recurrence curve is shown on the left. The survival curve is shown on the right. And here you see about a 15% reduction in the risk of death and about an absolute gain of about 2% at 10 years. And this is a meta-analysis of just under 10,000 women in these trials. So remember those figures: 15% reduction in risk of death, 2% gain, from a large meta-analysis. What about treating for longer? We know from trials such as B42 that's shown here that after 5 years, whether it be an aromatase inhibitor up front or tamoxifen followed by an aromatase inhibitor, if you randomize a patient to then ongoing treatment versus nothing, you further can reduce risk of recurrence. Again, hazard ratio about 0.72, absolute benefit just under 2%. And the factors that drive that are really lymph node burden. So the greater the lymph node burden, as you can see in this meta-analysis, the greater the benefit of extending therapy. And if your nodes were negative, I think you need to have a clear discussion with the patient as to really whether there is benefit of going beyond the 5-year point. You might do if it's a grade 3 cancer. But what's the impact of that on overall survival? Well, this only really came to light in the meta-analysis, and this was published last year in The Lancet, if you haven't seen this paper. And again, now this is an analysis of all the trials of extended therapy, 12 of them in total, 22,000 women. And while you can see a reduction in recurrence rates, as you can see on the left, the impact on overall survival is not statistically significant. Now, it may be that there are subgroups, those with 4 or more nodes, where there is really an impact on survival. But if you take all patients and say 10 years versus 5, does it improve survival or improve cure rates? The answer is no. Now, in premenopausal women, these two papers changed clinical practice just over 10 years ago. And this was the early publications of the SOFT and the TEXT trial, looking at the role of ovarian suppression in premenopausal women, either with tamoxifen or with the aromatase inhibitor. And we know from the analysis now of long-term follow-up, 15-year follow-up, that was presented at ASCO last year by Prue Francis, that in those patients under 4 who are premenopausal, who perhaps need chemotherapy, then there is a clear impact on overall survival. You can see that in the panel on the right. Whereas the panel on the left shows that if the patients have got better prognosis disease and don't need chemotherapy, then the impact of overall survival from ovarian suppression is pretty negligible. So again, this allows us to have our discussion with patients about those where we really feel ovarian suppression is important, not only because it reduces recurrences, but it potentially cures more patients. So overall, we have over 20 years gradually made impacts on improving overall survival. The biggest impact was tamoxifen versus no treatment. These are the survival data. I showed you earlier the recurrence data. Taking tamoxifen compared to no treatment, 30% reduction in the risk of death. Absolute difference at 15 years of just under 10%. This is the biggest evidence that endocrine treatment cures more patients. Aromatase inhibitors a little bit better, 2% absolute difference, 15% reduction in death. Extended therapy, not an impact on survival. Ovarian suppression probably does in a group of patients who will definitely benefit the most. So that was about 20 odd years of work to really try and improve survival in early breast cancer with different options of endocrine therapy. So let's now move to the meat of the talk, which is really looking at where CDK4/6 inhibitors have come in to enhance the benefit of endocrine therapy. We've had these therapies in metastatic disease. They've transformed practice. What can they do in early breast cancer and who benefits? Are they now needed for all patients? And how do we manage the adverse events? Because they do have toxicities, and that's important to understand to enable we can keep patients on treatment. So the premise of CDK4/6 inhibitors is based on this cartoon here, and I think it's always important to just understand why the treatments work. And this is the cell cycle, and it's regulated by a bunch of proteins, cyclins, and CDK, cyclin D kinases. And CDK4/6 and cyclin D is the key regulator of the G1S transition phase. And hormone receptor signaling, as well as mitogenic signaling from growth factors, activates this pathway by phosphorylating the RB protein, releasing the E2F transcription factor, and driving growth through. And if you inhibit the CDK4/6 pathway, you stop that phosphorylation and you stop the cell growth. And cyclin D, we know, is important in ER-positive breast cancer, and resistance to endocrine therapy is associated with a strong dependence on cyclin D1 and CDK4/6. Hence the reason CDK inhibitors work in metastatic disease to overcome endocrine resistance, and hence they work in ER-positive breast cancer in particular. So what about the trials in early breast cancer? How have they been designed? Well, they've looked at this sort of bell-shaped curve of risk of recurrence, which is driven by stage. The higher the stage, the higher the rate of early recurrences. And then it drops off after a few years. But as we saw in the PAN data, the recurrence risk never disappears. The curves never drop down to zero. So they've selected patients with various stages, and they've looked at either 1, 2, or 3 years of treatment with each of the different drugs. This table here summarizes in one table all of the data. The two palbociclib trials, unfortunately, were negative. One post-neoadjuvant therapy, Penelope B, one a definitive adjuvant study, Pallas. Monarchy and Natalie with abemaciclib and ribociclib respectively were both positive, and we'll go into those in detail now. And I've just put in here for completeness a study presented at ASCO last year with dalpilisib in China, which again was a positive trial in a high-risk patient population. So this is the data in over 22,000 patients now of CDK inhibitors. Let's focus on Monarch E, which I've had the great privilege of being the PI for. And this was designed nearly 10 years ago when we sat down and tried to understand who are the patients that need more than current chemotherapy and hormone treatment. And we went back to those features that I showed you at the beginning, 4 or more nodes, 1 to 3 nodes, an additional factor such as grade 3 or large tumor size. This is the so-called cohort 1 in the trial. So we've got node positive, high risk early breast cancer patients. A second cohort was added at the behest of the regulators, the FDA, who asked us to look at 1 to 3 nodes with perhaps a smaller tumor, perhaps a smaller size in grade, and perhaps a high proliferation to see if biology mattered. So the intent to treat population is both. Cohort 1, which is the approval of the drug in many countries, is based on the high risk only. These patients all had their standard surgery, radiotherapy, and 95% had chemotherapy because they were high risk. And then they were randomized in an open label fashion to either endocrine therapy alone or endocrine therapy plus 2 years of abemaciclib, and then continued their endocrine treatment out to 10 years. All patients were staged to make sure there was no metastatic disease, and recruitment was over a 2-year period, 2017 to 2019, with primary objective invasive disease-free survival. And this is the primary endpoint with the 5-year data, and the trial is positive. But look first at the blue line. The blue line is the endocrine therapy alone arm, and it's really important when you do a trial to see in your control arm if it behaved exactly as you thought it should do. And the answer is it did. 1 in 4, 24% of these patients relapsed at 5 years. They'd all had chemo, they'd all had the best endocrine treatment, and they were relapsing at a steady rate. The abemaciclib in the red starts to improve the outcome, and the curves separate during the treatment period and continue to separate between the years 2 and 5, this so-called carryover effect, where benefit continues to emerge long beyond completion of treatment. The hazard ratio is the area between the curves. It represents in this particular analysis a 32% reduction in risk and an absolute difference of 7.6%. So of those 1 in 4 who are going to relapse at 5 years, nearly a third of them could be prevented from having a cancer recurrence by the CDK inhibitor. Now, the survival analysis at that time point wasn't mature. So the more recent analysis that we did and presented at ESMO last year and published in Annals of Oncology is the event-driven survival analysis, which needed 650 events to trigger that. And the follow-up was now 76 months. And it gave us an estimate of the 7-year risk of recurrence. The overall survival is statistically significantly improved. There's a 15.8% reduction in the risk of death, absolute difference just under 2% at 7 years. It takes out to 5 years before the survival curves start to separate because patients have to develop metastatic disease, go through their treatment, and then see differences in the death rates between the two arms. But there is a significant reduction, 301 deaths compared to 360 in the control arm. And this is the very first time that a new therapy added to hormone treatment has improved survival in early breast cancer. And I showed you earlier It took a meta-analysis to show that aromatase inhibitors had this same 15% reduction in risk difference of 2% over tamoxifen. Here, one trial, 5,000 patients, can show it. Now, I think this is a really important slide to understand why that survival difference is emerging. And it's all to do with a lower burden of metastatic disease. So in green in this histogram, you see the number of patients and the percentage developing metastatic disease, and they're alive and having treatment at the time of the analysis last year. In the light pink, it's those who sadly died from their breast cancer. And in the dark red, it's those deaths not related to breast cancer, vascular infection, road traffic accidents, whatever. Those are relatively similar between the two groups. But you can see that overall, the burden of metastatic disease is reduced by about a third. And if that continues to emerge with further follow-up, and those patients were getting a much lower incidence of metastatic disease, we expect the differences in overall survival to continue to diverge and magnify over time. Now, IDFS is the analysis that is the primary endpoint. These were the updated 7-year data now. And again, the separation of the curves is now stabilized between years 5, 60 months, and year 7, 84 months. So the curves are separated and then they've stayed constantly apart. So this is the latest overall data on the IDFS benefit. And again, most of these events that were prevented were distant recurrences. There's an impact also on local regional recurrences, dropped from 109 to 70, and a reduction in contralateral breast cancers, no difference in second primaries. And the majority of of sites that are prevented are bone and liver, as you would expect. Now, these were data that Javier Cortez presented at San Antonio just gone last year, and this looked at the breakdown in nodal groups, the N1 high risks, the N2s, that's 4 to 10, and the N3s, 10 or above. And again, you can see that the higher the nodal burden in the Kaplan-Meier curves, the greater the risk of recurrence, the poorer the prognosis. But the hazard ratios across the groups are very similar, showing the same degree of benefit of abemaciclib at reducing risk, regardless of nodal burden. In the left-hand side, the N1 high risks in the histograms, you can see that the tumor is less than 5%. It's all because they're grade 3. So that's what's driving it. In the N2s, there's a bunch of grade 2 tumors, which tend to often be the lobular cancers, which you know are the larger tumors. So what other factors can we use to see who really benefits? If it's not the nodal burden, if the benefit's not all in the high node positives rather than the low node positives, is it something else? What about Ki67? This is a marker of proliferation. A more aggressive cancer has a higher Ki67. Well, it's a very strong prognostic factor. Look just at the blue curves, the endocrine therapy alone arm, and solid is the high Ki67, dotted is the low Ki67, and you see the big difference in rate of recurrences. If you look in the red lines, that's the benefit of abema, and whether it's the high Ki67, the solid line, or the low Ki67, the dotted line, the benefit is the same. So this is the best evidence we have that it's a strong prognostic factor, but it is not a predictor of benefit to a CDK inhibitor. What about other aspects of biology? Well, my colleague Nick Turner presented now a couple of years ago the initial analysis that we've done of over 1,000 tumors, looking at whole exome sequencing, RNA exome sequencing, and allowing us to assess the molecular subtypes, the oncotype score, and the various mutations and copper number variations, and see if we can pull out patients who derive more or less benefit. Here's the assessment of oncotype score, and you can see in the pie charts that the majority had scores more than 25. Not surprising, it's grade 3 large tumors node positive. But whether you have a high or a low oncotype score, this is on a binary cutoff, the hazard ratios are broadly similar. Again, luminal A versus luminal B. You're not suddenly getting more benefit in the luminal B cancers. The luminal A cancers derive substantial benefit. It looks like the basals might be more interesting. Again, the numbers are very small, so the confidence intervals are wide here. But there's certainly data in metastatic disease that the very low ER, more basal-like tumors may not be a group that benefit. And we're doing a more detailed analysis now of over 4,000 of the tumors to look at this in more detail. Mutations we look at and understand in metastatic disease now to drive treatment options, as you know, and PIK3CA mutations are the most common mutation in ER-positive breast cancer, and you'll see them in primary tumors in just under 40% of them. And whether you've got a mutation or you're wild type, you still get benefit from a CDK inhibitor. So as you look down all these other mutations, they get rarer. There was an interesting potential signal in c-Myc as being a resistance marker. And again, we'll look at that in more detail in the larger data set. So at the moment, there's no biological feature that we can pull out that says you get more or less benefit from a CDK inhibitor. Let's briefly look at the other trial, Natalie, which was the study of ribociclib. And this trial differed from Monarch E in about 4 key ways. First, the dose of the drug was lower than is used in metastatic disease, 400, to reduce the rate of the neutropenia, particularly in patients after chemo. Duration was 3 years, not 2 years. And everybody was mandated to have a non-steroidal and aromatase inhibitor so that if they were premenopausal, they needed an LHRH agonist. But the trial also included node-negative patients, but those node-negative patients had to be high risk. And this goes back to what I showed you earlier with that real-world data, that if they're N0 grade 2, they had to have high oncotype scores or Ki67 or be grade 3. They could get in node 0 if they were larger tumor size. So again, they had to layer on top additional factors for those node negatives to be high risk. The trial was positive. These were the latest data presented at ESMO in the same session that we presented Monarch E by John Crown, published in ESMO Open the same day. And again, this is the latest data now out to 5 years. The curves separate during treatment, and there is this carryover effect that we saw in Monarch E, again in Natalie. Absolute reduction in risk, 28%. Delta is 4.5% at 5 years. So the trial is positive and the drug is approved in the wider patient population. What about this difference of nodal status? Well, this was really what everyone was waiting to see. Are these node negative patients benefiting? Are they high enough risk? And the answer is they are. If you look at the light gray, the control arm, you can see that 15% have relapsed at 5 years. So these are high-risk node-negative patients, and they derive a benefit. The numbers are small, so it is difficult to have true statistical confidence because it is a much smaller data set. The N1 to N3s are grouped together, so it's everything from a 1 centimeter grade 2 tumor right through to a 5 centimeter 10 node positive grade 3 tumor. Overall, again, statistical difference. And we haven't seen a breakdown based on their different nodal groups that we've just presented in Monarch E. Their survival data at the moment are immature. They don't have enough events yet. It's an event-driven analysis, and they'll have to wait and see whether or not a survival difference emerges. But numerically, there is starting to be a very small difference. So we have 2 trials now. They reduce recurrence and they reduce the recurrences that matter, namely metastatic disease. And as Angela de Michel, the discussant at ESMO, said, these drugs are here to stay. Monarch E is a higher risk patient population with more mature, longer follow-up. Natalie, a broader group, but widening the benefit to other patients. And this little chart here, I think, is helpful in your MDTs to say, well, who is eligible for a CDK inhibitor? Well, pretty much everybody now, apart from the T1 tumors, less than 2 centimeters, that are node negative. They are excluded. But as soon as you get to a T2 tumor, if it's grade 3, it's in. If it's grade 2, it has to have those additional factors. And when you get down to the high-risk node positive, then both drugs are options. A little bit about adverse events, because it's important to understand these and how we manage our patients in clinic. And these tornado plots side by side nicely demonstrate the differences between the 2 trials and the 2 drugs. We see diarrhea mainly with abemaciclib, and it's mainly low grade, but there's around about 7% that have high grade and need a lower dose, as we'll discuss. Neutropenia and fatigue, the other most common side effects, but neutropenia not as common as with Natalie, which is with ribociclib, which is a 3 weeks on, 1 week off drug, more likely to cause neutropenia. In Natalie, there is an increased risk of liver function abnormalities, and that can be a rate-limiting issue in terms of the toxicities with ribociclib. Both trials, again, show an interesting reduction in arthralgias and hot flushes when you add a CDK inhibitor. There are now 5 trials in early breast cancer that have all shown the same thing. So there is definitely something about reducing arthralgias and hot flushes and we don't understand the pathophysiology, but this has been a consistent finding in the studies. Discontinuations, if you need to do so, were around about 18-19% in both studies. Diarrhea for abemaciclib, liver-related toxicity for ribociclib. But dose reductions are important to manage adverse events. And this little table here tells you and these slides will all be available to you, the levels of dose reductions you go down to, the laboratory monitoring that you need to do, particularly in the first 2 cycles, to monitor for adverse events, both from biochemistry, hematology, as well as clinical, and how to manage those adverse events in terms of dose interruptions, dose delays, and the levels that you take the patients down to. If we just focus a little bit on the diarrhea with abemaciclib, when does it occur? It occurs early. The median onset is in the first week. It lasts around about 4 or 5 days. You need to stop, and you must prescribe loperamide initially to try and manage it. If the loperamide at full dose does not prevent the diarrhea, it's important to stop and then dose reduce if the toxicity is not resolving. And the ability to dose reduce then allows you to keep patients on study, and the overall incidence of ongoing low-grade diarrhea drops over time. So in terms of a nice little table to show you how to reduce the doses and when to make the changes, this summary, again available in the slides, will show you how to manage the different grades and when to dose reduce. Now, one of the questions has been, if you dose reduce, does it reduce the efficacy? And in metastatic disease, we've seen that it doesn't, and it's now been shown in early breast cancer as well. So we published this paper a couple of years ago now, and the 40% of patients in the trial had to reduce the dose, and then we compared their outcome compared to those who didn't reduce the dose. And the bottom line is that they're exactly the same. In fact, the curve that sits on top are the patients that actually had the biggest dose reduction. So it's the ability to stay on the drug for the 2 years is important, not the absolute level that you are on. And the same has just been published by Peter Fashing for the Natalie trial. So take the time with your patient in the first 2 months to get the dose right, and then they can stay on drug, and then that's how they get the benefit. So these drugs are approved, abemaciclib, 4 or more nodes, 1 to 3 with high-risk features. Ribociclib, all node positive, as well as high-risk node negatives. And at the moment, no biomarkers will identify the patients that derive more or less benefit. So one of the other key questions we think about is, will these treatments, if they're so beneficial, replace chemotherapy? In all the trials, patients had chemo, 95% in Monarch-E, about 85% in Natalie. But what about that more difficult, nuanced discussion of those patients I showed you at the beginning, the N0 and the N1 patients, where there was no real benefit if we believe TAILORx and RX bonded to chemotherapy, but we give CDK inhibitors. Will CDK inhibitors actually be better than chemo? Well, this is the really important trial to keep your eye on, called ADAPT Cycle, that the colleagues in Germany have recruited to now, and we expect data in the coming years. And this looked at this intermediate group of N0 and N1 in the yellow there, dependent on whether they've got low or high oncotype, low or high suppressed Ki67 after short-term exposure to an AI, and is randomizing patients to either a CDK inhibitor or chemotherapy. This could be a practice-changing trial. This could define the group that really don't need chemo and where the CDK inhibitors are better, because we know in metastatic disease, the head-to-head comparisons again show CDK inhibitors are better than chemotherapy. Now, I was asked to put these Real Alliance Canadian slides in for you guys, which really just identifies where CDK inhibitors have come into your algorithms of treatment options in the early breast cancer setting. I don't propose to go through it, but basically it is very clear now that both in pre and postmenopausal women, we assess the level of risk, whether it's just low risk, and those patients can have endocrine therapy alone, or whether it's medium to high risk, and we add the CDK inhibitors plus whatever additional treatments we may wish to give these patients. So all of the data from the CDK inhibitors is now being incorporated into the majority of international guidelines. So my final 2 or 3 minutes, I'm just going to have a little glimpse of where we're going in the future. I've gone back and shown you the progress over the last 20 years of hormone treatments improving overall survival. And we've looked at where CDK inhibitors have really made a big impact and have come into clinical practice in the last few years. And now they're improving survival as well, as we can see in the Monarch-E trial. But what about these other therapies called oral SERDs? Are these going to be the next generation of hormone treatments? And what is a SERD? Well, the cartoon shows that a SERD is what's called a selective estrogen downregulator, receptor downregulator. So it basically targets and destroys the receptor, whereas in the middle, the SERM drugs, tamoxifen, don't destroy the receptor. They allow the receptor to sit on the DNA, liganded to tamoxifen, and they just regulate different genes, but switch off proliferation. Whereas aromatase inhibitors just take away the ligand so the receptor doesn't dimerize and doesn't drive the genes. Now, in old days, we had a drug called fulvestrant, and in studies in metastatic disease with fulvestrant, it was no better than an aromatase inhibitor. And in more recent studies, when we've added a CDK inhibitor, the Parsifal trial, again, no better than an aromatase inhibitor combination. So up till now, fulvestrant was the first generation SERD that we had. It came into practice again around about 20 years ago in metastatic disease, but it has poor bioavailability. It's an intramuscular injection. It's not the most user-friendly drug. So all the companies have been working very hard for a number of years to develop oral agents. And the list here of SERDs gives you the number that are in development. The ones that have now got names have graduated into trials. And if they're in green, they've actually graduated into approved treatments in metastatic disease for ER mutant breast cancers, because mutations in the receptor called ESR1 mutations develop over time during exposure to hormone treatment, and the oral SERDs are better than fulvestrant at targeting the mutated receptor as well as the wild type receptor. The two blue ones, camizestrant and giredestrant, are still in clinical trial development. Amcenestrant died and stopped its development. And in early breast cancer, there are trials going on to see where these drugs would fit in. And these are the light turquoise blue tables at the bottom. And it's split into two groups. The lidERA trial and the Cambria 2 trial are head-to-head comparisons of either giredestrant or camizestrant versus standard endocrine therapy. And there are subsets that have CDK inhibitors involved. This bottom group, Cambria 1, Elegant, and Ember 4, are trials what we call switch. So after 2 to 4 years, including a CDK inhibitor, then patients may switch to a SERD or stay on their AI. And these are ongoing trials. And I suspect the latter here are the ones to really watch, because that might be picking up the acquired resistance of ESR1 mutations in the adjuvant setting and preventing that. And we've seen already a principle of that in metastatic disease with Serena-6. lidERA gave some results at San Antonio, and this is the very first oral SERD data in early breast cancer. It was a head-to-head comparison against standard of care in stage 1 to 3 disease, but there was no CDK4 inhibitors. These were a trial was set up before the CDK inhibitors came into practice, but the trial is positive. So for the very first time, a SERD is better than standard of care. And you can see in the forest plot, much better than tamoxifen and definitely better than an aromatase inhibitor. So if these become approved, they could be really important because by and large, they have better toxicity. There is less arthralgia, less of the hot flushes with these drugs. The key thing is, how do they perform combined with CDK inhibitors? And we have to wait and see of those studies in metastatic disease, and also how best we use a monotherapy option in the early breast cancer setting. So my final slide shows that really there's enormous development in ER-positive breast cancer coming from targeting the receptor, but also targeting the resistance mechanisms. And in metastatic disease, you can see in purple the new therapies over the last 15 years that have become approved because of the way to target resistance. And now in early breast cancer, CDK inhibitors are here, oral SERDs are starting to come through, and I anticipate in next 10 years we will have combinations in early breast cancer to really prevent resistance and improve outcomes even further. So Jennifer, I'm going to hand back to you for our Q&A session, and I'll hover over this slide here to say thank you for listening, And please also complete the post-test and evaluation of this program using the QR code there. So I'll leave it on and not stop sharing yet, but Jennifer, pass back to you for 15 minutes or so of Q&A.
Perfect. Thank you very much, Professor Johnston, for that excellent presentation. Very informative about a huge area that's really changed our practice in early breast cancer. And thank you everyone for being here over your lunch break today. I'd just like to remind you that if you have any questions, please put them in the chat so we can go through them now. And that those QR codes, there's also a link, it looks like, in the chat where you'll be able to access the evaluation as well. But maybe while we're waiting for some questions, I'll just start off. As you kind of highlighted, there's a huge overlap between patients who would have met the Natalie criteria versus those who meet monarchy. In your practice, how are you deciding which CDK4/6 inhibitor to use for those patients?
No, that's a really good practical question. And the first thing to say is I'm really pleased that we've got two options now. It shows that it's a class effect. There are separate reasons I think why palbociclib didn't work, but it's good that we've got two options because the drugs have different profiles and particularly different toxicity profiles. And there's the opportunity if a patient's eligible for both and struggles with one that you can use the other. So that's really helpful clinically. I think for the high risk node positive patients, those that really meet the monarch E criteria, and particularly sort of N2 and N3s, there is real mature data now out to 7 years with a survival benefit showing the benefit for abemaciclib. So I think that by and large is the first choice. And when I've looked at market data from both Europe and the US, that tends to be what is reflected. People, I think, like the maturity of the data and now the survival benefit. Yes, there are issues to make sure that people understand the toxicity and manage it to keep patients on therapy. And we can talk a little bit about that and dose and so on in a minute. I think for ribociclib, it's those N1 patients now that don't meet the monarchy criteria. But again, maybe some of the N1 patients that are abemaciclib, people have opted to give ribociclib. I think it's also a question of whether a patient is up for 2 years versus 3 years because patients sometimes are a bit fed up at the end of their chemo and radiotherapy. It's really important you message them that these treatments are coming for them in their treatment plan, so it's not a surprise. Because if you leave it too late to talk about it, your patients will say no. And the other practical issue in choice is the role of tamoxifen because it's not allowed with ribociclib. It is allowed with abemaciclib. And if you have a premenopausal patient where Zoladex and tamoxifen is your preferred hormone option rather than really driving them with OFS and an AI, abemaciclib is what you can use, whereas you can't use ribociclib. So a combination of factors, I think, allows us to make a decision.
Thank you. And kind of to build off of what you had mentioned, the toxicities certainly are different between the two. I know there's been some studies, such as the TRADE study, looking at more of a dose escalation approach. That was for abemaciclib. What are your thoughts about that strategy? And have you been using it, or have you seen people using that sort of strategy in practice?
Yeah, I mean the licensed dose is 150, and trade was a really important study from colleagues at the Dana-Farber, published in the Annals of Oncology exactly the same time as the monarchy, so it's in the same issue. And I think it's a lovely study. It's 50 milligrams BD for 2 weeks, 100 milligrams to BD for 2 weeks, and then take them up to 150. And they got more staying on 150 than if they went straight on it. And we know in clinical practice that other drugs that are developed, when we get them into practice, we learn how to use them differently. Everolimus, I start at 5 milligrams and you build up to 10. That reduces the stomatitis. Capecitabine, nobody uses it 2,500 milligrams per meter squared, it's 2,000. So we've learned, and abemaciclib was originally developed at a 200 milligram dose, so it was far too toxic. So I think we learn. And if we've got a frailer older patient, do I start them at 100 rather than 150? Yes, I have, because it's the ability to stay on the drug. But by and large, we aim to start at 150 and drop them down if prompt management of the adverse events doesn't work. So I don't think trade has been taken up as how you should use the drug, but trade is just an example that tapering and managing dose can actually allow patients to stay on drug.
Thank you. And then, sort of also to build on what you had said, you had sort of mentioned really the importance of making sort of a roadmap for patients at the beginning. That way, when we're trying to add on these therapies, it doesn't come out as a surprise because a lot of these patients have received chemo, they've had their surgery, their radiation, and it's a long journey with a lot of toxicity associated with it. There's been some interesting data. I think it was from the Flatiron database about the uptake of CDK4/6 inhibitors in real world practice maybe has not been as high as one would think. Um, how have you found other providers or even where you work in terms of the use of CDK4/6 inhibitors, and what do you think some of those hesitations to uptake are?
That's a really important question, Jennifer. I think the issue is, and that you're right, it was in that Flatiron database that showed in the N1 patients, so that only 30% were getting abemaciclib if they were eligible. And this was before Natalie got approved, because Natalie getting approved, there's a wider uptake, I think. But even in the UK, when Monarch E led to approval, there was slow uptake, and it was a combination of we can't absorb this in clinical practice. We've got much more visits to see. We're already working. We haven't got the staff and the clinics to take this on. Versus, I think initially, if they hadn't been involved in any of the trials, being a little bit frightened about the adverse events and making adjuvant patients ill with these treatments, even though the drugs have been used in metastatic disease. So there is a little bit of a learning curve to get up and running. But I think the Flatiron database, understanding the true level of risk of these N1 high risk patients and also the N0 high risk patients, has helped really identify that these are patients where endocrine therapy alone is not enough, particularly if your oncotype comes back and says you don't need chemotherapy. And really, therefore, that the CDK inhibitors has quite a lot to offer these patients, particularly when chemo isn't being given. So I think uptake is gradually increasing. Obviously, now there's ribociclib as well as abemaciclib. I think there's more uptake. But again, what I'm finding is a reluctance now in the N1 good prognosis patients to say, do I really need to do it? So I'm talking about a 1 centimeter grade 2 tumor, low key 67, one node involved, oncotype score of 10. You know the type of patient I'm talking about who you're normally saying 5 years of hormone treatment is all you need. You've got an excellent prognosis. Do they need a CDK inhibitor? And that's where a dissection down in Natalie is lacking at the moment. So there is a concern among some that we could swing to over treatment here in terms of some of the lower risk N1 patients in particular. But the N0 high risks, I think it was very clear that they selected that group very appropriately.
Thank you very much. And we have a question from Dr. Rakovich in the chat. Do you think the added benefit of CDK4/6 inhibitors will have further implications on the future role of breast radiotherapy?
In terms of what, less breast radiotherapy or?
Yeah, less breast radiotherapy as recurrence risks are reduced further and further, then we're in a position always to then say, well, is radiation needed?
Yeah.
So do you think that there's enough of a reduction in risk that again, future trials will ask if it's necessary or evaluate the omission of
No,
radiotherapy?
it's a good question. I hadn't really thought of that to date. The local recurrence risks were less with the CDK inhibitors, but pretty much everybody got the radiotherapy. The issue is really where you're emitting radiotherapy in some of the patients with perhaps better prognosis disease. Can you mitigate that risk with a CDK inhibitor? I'm not sure yet, because to my mind, a lot of this is all about stopping metastatic disease. And I think I'm not a radiation oncologist, so I think there's still an enormous role to play in reducing local regional recurrence, dependent on the type of the surgery and the pathological features that drive risk of recurrence, whether it be margins, closeness, tumor volume, etc. So I'm not sure it's a way of reducing radiotherapy yet.
Right. Thank you.
Thank you. If anyone else has questions, please feel free to put them in the chat. But maybe in the meantime, another thing that I think a lot of people worry about is What do we do now when patients recur or in the metastatic setting now that we're using CDK4/6 inhibitors earlier, as those are our first line therapy, typically in hormone positive breast cancer that's metastatic? And I guess especially, what about for those patients who recur while on an adjuvant CDK4/6 inhibitor or very shortly afterwards?
No, I think it happens in all therapies as we move them up the escalator from metastatic disease into early breast cancer, doesn't it? That we, if they relapse, have we burnt our bridges in terms of using them? And herein there's a data gap in truly understanding it, but the principles have often been to use that year gap since the end of therapy. So if patients are relapsing more than a year after they have completed that therapy, it's not unreasonable to treat them as potentially still sensitive and use the combination. But you're right, if they're relapsing on their CDK inhibitor, that's looking by and large at more aggressive disease. We've tried to ensure in the monarchy trial, we're trying to get biopsies as often as we can in those patients relapsing to understand the biology. Some of my early patients in the trial, definitely had ESR1 mutations. You pick up the PIK3CA mutations, and although they're not a resistance mechanism, PIK3CA to CDK inhibitors is often a sign of a more aggressive cancer in the metastatic setting in particular. And we've got other targeted combinations that we use. So I think what happens if you relapse early in that setting is you're straight into your sort of second line scenario options that we're developing in metastatic disease. And as you know, we've rapidly moved on from just monotherapy with fulvestrant or exemestane to now combinations. We've got a lot of interesting data. Avira with the SERD, looking at SERD plus everolimus as a really helpful combination. We've got, some of the other datas that have come through with gedatolisib, the Victoria trials, looking at triplet combinations, regardless of mutations in the PIK3CA pathway. So we've got a lot of interesting combinations coming through, and they may become the front line for the patients relapsing on the CDK inhibitors. Biopsy, biology, all the time important to drive decision making.
Thank you. Absolutely agree. And while we have a couple more questions or minutes left, maybe my last question is you presented the lidERA data, and as you'd mentioned, those patients did not receive a CDK4/6 inhibitor. How do you see sort of incorporating the two in real world practice in the future?
I mean, that was interesting because it kind of was one of the key questions that was asked at the San Antonio discussion. I wasn't there, but I heard it in terms of, if the drug was available now and everyone's getting a CDK inhibitor, where would you use it? And the majority of the people were saying, well, I'd probably put it into a switch strategy as soon as the patients have finished their CDK inhibitor, because if they're working then, they'll probably work later. So the other area where it might get used is those patients that fall outside the usage of a CDK inhibitor. So the T1 N0 tumors, if there's a better toxicity profile, then this could clean up as being a better option than the aromatase inhibitors for your low risk patients. So I think in upfront therapy, it might come in there. The slight caveat to the problem is that the combination of giredestrant and a CDK inhibitor in the Persevera trial was no better than an AI and a CDK inhibitor. We've only seen a press release. We haven't seen the data yet. We may see it at ASCO or San Antonio. But essentially, the head-to-head of SERD CDK versus AI CDK inhibitor in metastatic disease was negative. I think we need to understand that in more detail. So at the moment, I think watch this space. But if I had to put a bet on it, it will come in as a switch strategy as monotherapy later on, as soon as one of those Cambria-1, Elegant, or Ember-4 reports out. If they're positive, that's where they'll fall into practice.
Thank you. Certainly, as we have more and more therapies available, it's more exciting but creates more and more questions
More
for us
complex.
at the
Yeah.
same time. Yeah, exactly. So with that, I think we just have less than a minute left. So if there's no other questions from the audience, I'd like to say thank you again. That was a really excellent presentation, and I think we all took a lot away from it. Thank you, everyone, for joining us as well. And just a reminder, there's the evaluation link that's in the chat, and I believe afterwards you may get via email or certificate of attendance, or Antoinette maybe taking that as well. But thank you again, Professor Johnston, for joining us. That was really excellent.
Great. Thank you very much, Jennifer, for moderating, and thank you everybody else for joining in your lunch break, and for the guys putting the program together. Thank you.
Perfect. Have a good afternoon, everyone. And thank you, Eli Lilly, as well.
Yeah. Thank you now.
Take care.
Bye now.